I am Larry Nissen, Chair of the IOMS Foundation, and would like to welcome you to this portion of the IOMS Foundation podcast celebrating the Foundation's 25th anniversary. This episode will highlight the activities of the Foundation's Committee on Global Surgery. This group is responsible for overseeing the areas of humanitarian aid and disaster relief globally. Dr. Steve Roser is chair of this committee, our association's representative to the G4 Alliance, and will also moderate this session. I will turn it over to him now to briefly discuss the G4 Alliance, the committee's efforts, and introduce the podcast participants. Dr. Roser, thank you for being with us.
Thank you very much, Larry, and thank you for the opportunity to have the committee come together and talk amongst ourselves and share some of the great work that the committee members are doing individually and collectively. You mentioned the G4 Alliance. Thank you very much. IAOMS Foundation is a member organization of the G4 Alliance. Briefly, the G4 Alliance it's an advocacy organization made up of over 70 member organizations worldwide. And the vision is universal access to quality surgical, obstetric, trauma, and anesthesia care. And that is a goal of 70% or 80% of the world by 2030, an ambitious goal for access to care. It is an advocacy organization. It has developed some products, standards of care, and so on. But really what being a member of the G4 Alliance does for IAOMS Foundation is it gives us access to the global surgical space, which is huge. So many facets to it. But it brings together 70 really influential organizations in the global surgical space, including nursing, including midwives, including anesthesia, and so on. In addition, enhancing our visibility to those organizations and giving us access to shared best practices and work of the other member organizations. So I look forward to our continued participation with that. And I know Melissa Amundsen, which I'll introduce shortly, was the ACOM's representative to the G4 Alliance. But we'll bring her into our network and have her work for us. So we're going to have some fun with the podcast. We have some really special committee members. Not all the committees here, but a number of them are. And I'd like to introduce them. Live from Australia, Doctors Barbara Woodhouse and John Arvier. Both are in Australia, practicing in Brisbane. Both have been practicing for a number of years. But very specially, Barbara and John have started Operation Interface, which works in Cambodia and Africa. John works with OSHEAL, as well as Smile Cambodia, an organization, a part of Operation Smile. Both have done work in the global surgery sphere for a number of years. In addition to Barbara and John, Shahid Aziz, another one of our committee members, who's currently a professor at Rutgers, also the Associate Dean for Global Health, the co-founder and president of Smile Bangladesh. That is an organization that he started, has been together since 2006 in Dhaka, Bangladesh. They're hosts at the East-West University. They have operated on over 1,500 children with cleft lip and cleft palate deformities. In addition, we have from the Columbus area in Ohio, oral and maxillofacial surgeon, Dr. Byron Henry. Byron and his wife, Stacy, have founded the Free to Smile Foundation in 2008, which provides cleft lip and cleft palate cleft lip and cleft palate surgical services to a number of kids and adults across the world, including Nigeria and Africa, Zimbabwe, Philippines, Sierra Leone, and others. Free to Smile Foundation has supported over 50 surgical outreach programs over 2 decades. And last, but certainly not least, Melissa Amundsen, who currently is in Fort Lauderdale, Florida, in practice, has distinguishing feature, I guess, a distinguished role of being the only American oral and maxillofacial surgeon on the Doctors Without Borders MSF Foundation, which he's worked in Nigeria, as well as working with Operation New Life in Tegucigalpa in Honduras. So, lengthy introduction, but I could not pass the opportunity to give you some background. So when you listen to these folks, you know that they speak from a world of experience. So let's get started. We'll start with Barbara and John. We'll mention the pandemic a few times, I'm sure, and I maybe shouldn't start with it, but let's go with it. I'm assuming that you haven't traveled to do any work on any global surgery outreach programs since the pandemic started. Maybe I'm wrong, so correct me. But what was the last outreach program that you participated in, Barbara?
The last time I went anywhere was December 19, and it's all been suspended since then. We got shut down in February of 2020, and I don't think John has been anywhere in 2020.
That's correct. My last trip was with Smile Cambodia in September 19, and had a couple more trips planned last year, but they didn't occur. Yes,
I'm sure we could all share that experience. Barbara and John, tell me, because you have been working with those groups and in these outreach programs and have been making an impact, what's happened to these patients that you would have ordinarily taken care of?
The focus of our efforts is not in treating patients, but in educating local doctors. And we've actually set up formal education training programs in 3 countries, Bangladesh, PNG, and more recently Cambodia, and are contributing to a formal education program for the Vanuatu surgeons through University of Fiji. So in essence, our efforts are now being tested in seeing if they can function without us. And so far they're doing pretty well. We do support by email and Skype and FaceTime and WhatsApp and all the other media interfaces that are now available, thank goodness. And some things are being put on hold, but the majority of patients are being treated by the guys that we've already trained.
Great. John, any additional comments?
No, I just endorse Barbara's comments. I mean, it's been quite gratifying that the 3 countries where we've had training programs, and I perhaps could briefly hark back to the meeting in 1999 in Washington, the study day prior to the IOMS meeting. We had a consensus day on aid to the third world. One of the main recommendations that come out of that was to establish programs in the countries we visit, so some expertise is left behind. And that's not just long-term, like the situation we face now where we can't visit, but even in short-term, because invariably complications do occur, sometimes weeks down the track with bony surgery and healing. And it's a relief, really, to know that we've got people in those countries who perhaps their training doesn't quite measure up to first world, but are capable of addressing most complications and also conversing with us via the various technical aids we have, like the Zoom meeting we're having now. Yes, I endorse Barbara's comments completely.
We've even managed to make a case of necrotizing fasciitis by email, and the patient survived, which is no mean feat if you have any understanding of the facilities which are available to our trainees.
Great. Barbara and John, thank you very much. It must be just incredibly gratifying to have had this experience, perhaps a little silver lining in the pandemic shutdown, to know that you're making an impact. And in reality, education, training, research are the sustainable parts of the humanitarian outreach programs that as in the higher resource countries, we should be putting into place, increasing capacity. So thank you for those comments.
Just have one more. Unfortunately, the corollary to that, of course, is that those countries are even more affected by the pandemic than we are.
Yes.
Their testing rates are poor, their documentation is poor, the rates of spread are unknown, and the hospitals that are flooded at the best of times are even more under strain at the moment. So when those colleagues say to us, what can we do about the pandemic, there's no easy answer. So it is sad that they're affected more so than we are.
Thank you. Shahid Aziz, I'd like to ask you the same question. Smile Bangladesh has been in place for a number of years. What's going on now? You haven't traveled since beginning of 2020?
Well, first of all, thanks for having me on this podcast. It's really a great opportunity to talk and share our thoughts with everyone. So our last mission, we typically travel to Bangladesh because of the weather every March and every November. So our last mission was November 2019.
Great. So what's happening there? Are local counterparts taking care of the education and patients that been working on over these years?
Yeah, it's interesting. Our sort of charge in Bangladesh has evolved in the last 16 years, where initially it was focused on facial cleft surgery, and then about 5 years ago we started evolving into not just cleft surgery, but also orthognathic surgery. And we're actually doing a lot of teaching in orthognathic surgery over there. So it's sort of interesting where with technology, we're able to, as Barbara was saying, we're able to sort of talk to our colleagues in Bangladesh about patients. I've done some orthognathic consults via FaceTime, via Skype, via WhatsApp. And I've also been able to see some of our cleft surgeries post-ops, the ones who've had some minor complications or whatever. They've reached out to me, and we sort of talk about, okay, this is what's happening next. We're really hoping to go to Bangladesh this month, in March 2021, because our core team all were vaccinated, but unfortunately there's no the government in Bangladesh has no sort of vaccinated policies, and we'd have to quarantine for 2 weeks, in Dhaka, in a government facility prior to being allowed to do anything. So we obviously weren't able to do that. It's just too much time away. But hopefully in November we'll be able to change that. But, technology is such that it's really obviously from what we're doing on Zoom to WhatsApp or what have you, it's really allowed us to continue our mission remotely and continue educating and continue patient care. I think the one thing that'll come out of all of this is for all of us, whether it's here, whether it's in Bangladesh or other parts of the world, we all have increased our ability to work remotely. And I think that's going to be a game changer for global surgery.
Great. Thank you, Shahid. Byron Henry, Dr. Henry, you also, with your foundation, have a cadre of folks that really expect you to be working with them, supporting the local hosts. What's been going on in the last year and a half with your foundation and your experiences?
Sure. Well, I want to echo Dr. Aziz's comments and thanking you for having me as part of this. It's truly an honor to be here and to be amongst such compassionate and empathetic people. So it's great to meet you all as well. The last mission we were on was actually in February, when all of this was kind of in the beginning stages of blowing up to Guatemala. Since then, our projects it's a bit dichotomous where we go, because in our Ethiopia project, for instance, there is a local surgeon that we've been working on for several years who now does fairly good cleft surgery. And so he's been able to continue the use of his skills that he's been taught by our organization and other great organizations to continue the work. And like the others have spoken about, the technology is very, very helpful in that occasionally he'll email a case or ask for advice via WhatsApp or via email, which is, it's been very, very fantastic to allow him to be able to have that access to myself and others in our organization to help him along in the surgery that he may do. Guatemala is a different story, as many of you can attest to probably. The difficulty in finding a local surgeon and keeping them interested to do free work for the impoverished is a very difficult task. And we've encountered that in Guatemala, particularly, where we can't, we've had several surgeons local that have been in, but very often they come for a trip or two and then they're finished. So obviously our ultimate goal is to teach the local. But in that particular site, we've been blessed to have a young lady that has been working with us for 10 years. So she's very, very versed in taking care of these babies. But there are now 400 of them that have been born through this year. And so she has sent us a picture of just about all of them. And we actually go on our next mission here in 13 days. So we're leaving in a couple weeks, essentially, to go down there and begin the process. With that, we they have a protocol in place where all the families are vaccinated or are tested before the surgery. All the families that are with them are tested before the surgery. So, in some of our programs, the work is continued. Some of the others, the children have continued to be born without being treated. And as you know, it's tough to treat without access there. It's tough to treat them. So we're going to hopefully make a dent in that as the year goes along.
Great. Thank you very much. Melissa, I think continuing on sort of the same question, but tell us a little bit about your work with MSF as an oral and maxillofacial surgeon and what's been going on perhaps this year with the pandemic.
Sure. So MSF is typically an organization associated with kind of mass casualty incidents, a more public health kind of structured organization. The project in Sokoto, Nigeria is a real departure for them. It's Noma Children's Hospital was taken over from the now defunct Noma project, the Dutch Noma Foundation. MSF took the hospital over in 2015 to restructure patient treatment in Sokoto, Nigeria, in a pre-existing project that was failing. And so as an oral and maxillofacial surgeon with this project through MSF, our goal is the treatment and reconstruction of Noma patients in northern Nigeria, southern Niger, is primarily the catchment area. MSF, again, it's an unusual project for them because it's not acute medicine. It's a long-term project that requires, a lot of these patients require several different procedures serially. So it's also a teaching project as well, trying to ultimately hand the hospital back over to the Nigerian MOH once they are able to stand alone. So my role is primarily trismus release. You'll see a lot of really, really bad ankylosis cases secondary to early debridements from Noma as children. And then the post-operative PT is really not managed. So they develop these really large ankylotic masses. So I do trismus release primarily and some local regional flap reconstruction for like paramedian nasal flaps and those kind of things. We're teamed up with a facial plastic surgeon. So it's a collaborative project between the two of us, two U.S. surgeons, and then also we're training two local Nigerian surgeons.
Thank you. Noma. I didn't know much about Noma, but learned some about it. That is, it's a horrible outcome. But it apparently is pretty preventable if you catch it early.
So that is the real mainstay of the project. Ultimately, with the involvement of MSF, we've started doing research. That's one of the biggest defaults in Noma is not only is it preventable, we know that it's preventable, but how to prevent it beyond feeding your population. We know that nutrition is a major component. What else can we do to prevent this from occurring? I mean, it has this mainstay in sub-Saharan Africa, kind of known as the face of poverty, and it's been eradicated even in some of the other areas of the world that have similar kind of socioeconomic circumstances. So with MSF, we've also started doing more structured research on not only the etiology of Noma, but prevention, how that even community outreach, so to speak, because there's a lot of stigmatism with Noma patients involving, religion and certain just degrees of how people, because it's such a scary looking disorder, these children are often, shunned from society, and how we can actually educate the population into early treatment. And even just with early treatment, we've seen a major decline in mortality rates, but even with mortality rates declining, the morbidity is obviously quite high. And so there's a balance there, but we know it's preventable. And that's another one of the long-term aspects of the project, is just eradicating NOMA.
Great. Thank you. Thank you for sharing that. I'd like to go around the group again and to ask you a personal question. And that is, what is the most gratifying part of the experience that you've had in the global surgery sphere? Let's start with you, Dr. Henry.
Yeah, well, that's an easy question to answer, quite honestly. I mean, when you've done it for a long time, it's, I started doing this with several folks that are friends of yours, Dr. Roser, I'm sure, Dr. McIntosh and Dr. Herman and Dr. Burtz. And so, the most human experience I've almost ever encountered is one where you finish repairing a cleft lip, and then the family comes in and sees the individual for the first time. And you see their face, and you see the way that they break down when they see this brand new baby, perfect before and is even perfect now. But that experience, I think, from the first time I'd ever seen it, kind of just hooked me in. It's an unreal experience to be able to go over there when you live such a privileged life that we've had the opportunity to live as oral maxillofacial surgeons in the developed world, and we're able to go over there and give this skill that we've had the opportunity to gain, and then we're able to go over there and use that to help a family that in most cases would never have this surgery in a lot of these underdeveloped countries. And so it's incredibly gratifying to not only the family but to yourself internally to know that you're using these gifts that you've been given, and it's continued to encourage me for 20 years of doing it. So, but that human moment is nothing's ever better.
Your description was spot on. Doctors Woodhouse and Arvier, can you share with us what's the most gratifying part of your experiences with in the global surgery sphere?
Obviously, the appreciation of the patients is very gratifying, but perhaps more than that, for me, fulfillment comes in seeing the trainees acquire skill, understanding, diagnosis, managing patients in what we would see as a more gentle way. And some of our guys have achieved so much. You've got to remember they're just dentists. They're not medically trained like we are. And one of them actually pipped 4 or 5 plastic trainees at the post to gain a Nordhoff Foundation scholarship and spent a year in Taiwan learning cleft management, and came back and brought that back on an everyday basis to Phnom Penh. And that's, for me, that kind of stuff really tops it.
Oh, wonderful. Thanks. John?
Yes, just to echo those comments, I think the professional satisfaction is probably the words I use, and going to these countries and seeing the development of young trainees and just furthering the breadth of the profession that, as you said, we've earned a good living on in first world countries. You see millions of people living in poverty in some of these countries, and you realise how lucky we are to have been born into a developed country and had the education opportunities we've had. We had no say in it. It was just a pure chance. And you feel an obligation. The more you go back and I've got some great professional friendships with colleagues in other countries. Just getting Christmas cards from them and going to their houses. It's experiences that no amount of money could buy. Yeah, thank you.
Thank you for sharing that. That certainly is tremendously gratifying. Melissa, Dr. Amundsen, the most gratifying part of the experience is either with MSF or the other organization that you're working with, Operation New Life.
I'm seeing real change. I think Operation New Life is an excellent example. My last visit there was at the very beginning of the pandemic and was actually our last visit. So we have taken that project from dependency to self-sustaining management on their own. And the same with the NOMA project in Sokoto, although to a much lesser and slower degree. When I first started in that project in 2015, we were doing these large resections without even a CT scan. I mean, I was just freehanding it. And we've gone from no imaging to now ordering the correct imaging, and just seeing this slow but sure change in advancement gives me hope that, every year that we go back, or every other, quarter, there's a little bit of improvement. And that was really realized in the Operation New Life project, where unfortunately we're done, but that was the ultimate goal, was for them to be able to stand alone. And now they're doing it.
Thank you. Thank you for sharing. And Dr. Aziz, gratification from your hard work and efforts and with Operation Bangladesh, Operation Bangladesh. Smile Bangladesh.
Smile Bangladesh. So for me, it's similar to what everyone has said. On top of that, that's where I'm originally from. So there is a little bit of a special meaning to me, because I have a lot of family in Bangladesh that I never had the opportunity to really meet. Believe it or not, I have 60 first cousins, which I never met any of them until I started going there. And every time I go, I meet somebody new. So on a personal standpoint, I mean, that's amazing to reconnect with my father's family. Professionally, I mean, I agree with what everyone said. I think one of the things also that is really amazing for me is watching some of the local surgeons that we work with over the years progress in their skills and becoming sort of, as an educator for the last 20 years, watching them grow as surgeons and being able to think on their own. So that's very gratifying. So that's, that's why we're doing global surgery, really, is not to do, medical tourism. It's to, train those who otherwise wouldn't have the training so they can meet the local need. The other thing that's really important is, we've been taking American OMS residents from the beginning. And the reason I do that is not to make them, the second coming of Tessier. It's really to inspire them to give back in their careers. And unfortunately, there have been a few of them who have gone on to do humanitarian work, whether it's locally or internationally. And so that's, I think, really important, is because, we have to inspire the next generation of surgeons.
Great. Thank you. For our last round of answers, we could probably have a 1 hour discussion on, but I'd like to get your comments. The things that you've mentioned, education, capacity building, worldwide cooperation, friends, all of these things. IAOMS and the IAOMS Foundation is a international group of like-minded people, oral and maxillofacial surgeons. I mean, it's a very unique organization. How do we engage the foundation and our membership and the specialty in continuing to support or beginning to support these humanitarian efforts? What suggestions or advice? And I'll start with Melissa Amundsen.
Well, for me, I'm not cleft trained. And so most of my projects involve either trauma, orthodontic surgery, or something that requires hardware. And that's the biggest deficiency that I've seen in my projects, is access to hardware. It leads to a real limitation in care just from something as simple as that. So, that's my pie in the sky kind of hope, is that through the foundation some way, there are resources to supply hospitals with something as simple as hardware. In addition to that, the foundation's funding of resident participantship has been huge. Personally, when I was a resident, I couldn't afford to go on any sort of trips like this. And the fact that the foundation has offered scholarships to allow residents to travel and offset the cost of these trips is enormous. It's an enormous gift.
Great. Thank you. Thank you very much. Dr. Aziz Shahed, your suggestions, thoughts for the IAOMS and the IAOMS Foundation.
Well, I think, IAOMS has a great opportunity to connect the world of oral surgeons, literally. And I think what, at the Rio meeting, at our COGS meeting, we talked about, trying to create a database of opportunities globally. And that was, if I remember right, twofold. One is for, surgeons in developed countries who are looking to educate surgeons in developing countries, and vice versa, surgeons in developing countries who want to have opportunity to be educated and be mentored. And so I think, the obvious thing for all of us is financial. But beyond that, I think if we can set up some sort of a system where we can develop for the more senior people a mentorship program for those surgeons in the developing countries where, they may not have as great of access to certain things that, for example, we do in the States. As we know, maxillofacial surgery worldwide is very different. Here, it's only a small percentage of us do microvascular and malignancy as opposed to the rest of the world. But, as I've come to find out in Bangladesh, for example, orthognathics is something that they're 30 years behind. As Melissa mentioned, hardware is a big issue. And so I think mentorship and opportunity, and IAOMS is in a position where they can provide that. We just need to sort of come together, and the pandemic sort of derailed, I think, what Dr. Rose and I had talked about for the Glasgow meeting in September. But hopefully when we have another meeting again, we can start moving forward to that end.
Great, thank you for your insight, Dr. Xavier and Woodhouse. Your recommendations, your thoughts. How can IAOMS Foundation help?
Thank you. Firstly, I'd like to echo Shahid's comments about taking residents with us. It's inspiring to them, but more importantly, it is an incredible educational opportunity. They see the natural history of disease as they will never see it before or after in their own country, where, of course, it's treated in its infancy. And that's such an important thing. And I think the fellowship opportunities offered for the residents to do that are great, because we have a situation in Australia where we have no federal government funding if we take trainees, because they're super sensitive about being seen to experiment on the locals overseas. So we cannot take trainees if we accept federal government funding. So we eschew that funding and support ourselves to enable to take trainees. What else can we do? I'd like to echo Melissa's comments about hardware. That is a huge problem. I have a standing order at all the local surgical supply companies for anything that's being superseded. Send it my way. Maybe we could start up a used instrument collective in IAOMS. That would help, although obviously there's logistics about getting it from the top of the world where you guys are to the bottom where we are. But, you could have local collectives. That might be a thing. Perhaps the biggest roadblock that I see, and I'll give Ron some airtime in just a moment, is the actual cost to our trainees themselves. We're talking about a country in Cambodia where a large number of the population is earning less than $1 per day. And these guys have to pay $1,500 per year for 4 years to their university, and I would be very quick to say we see no part of that. That's purely the administration fees imposed by the university. Everything we do is completely self-funded. But they have to pay this, and that's a struggle for them, and that has other implications apart from meeting that cost, but also that they have to work outside the specialty to support themselves and their families and find the extra money for that cost. So any funding that the IOMS Foundation could direct towards trainees in underdeveloped countries would go a long way to breaking down those barriers. John?
Yeah, all good points. I just want to again hark back to that 1999 meeting in Washington when some fairly good guidelines came out of it, and we've tried to adhere to those over the last 20 years. I think that one of the best things that IOMS can do, and both of the body as well as the foundation, is have these regular meetings and perhaps keep publicising the efforts of everybody around the world to connect the world together, as Shahid said. The world is made up of a lot of developing countries as well as developed ones, and if we can connect them all together, and we have found that the imprimatur of IOMS gives us certain credibility within ANZOMS, which is the Australian New Zealand Association, which has then given me credibility. I've been very lucky in that I've had access to quite a bit of hardware from the firm Stryker that I've used over the years. I've pretty well eased out of maxillofacial surgery as I get older, but they've been very generous in letting me take a set of instruments and restocking my hardware every time I go. It doesn't address the long-term problem in those countries, but it has enabled me, I guess, to sort of show local colleagues there the way I do it, and then they can then use the pressure to often put pressure on their governments and their hospitals for a bit more funding, also to source relatively inexpensive hardware locally. Thank you.
Great. Thank you very much. And Dr. Henry, not last, not least, your thoughts. How can IOMS Foundation, IOMS help to further the access to care in the world?
Sure. Well, being last in this, the other three before me, or other four in this case, have done a fabulous job. They've obviously hit the main points. All of us, any of us that go on these trips, run organizations, obviously the thing that we always struggle with is financial, right? You can't go do the good work unless it's funded. And so there are so many great groups out there and individuals out there doing this work. And so one of the things that, as they've mentioned before, is the support of a couple of different facets. One being the residents and fellows. I like one of the other guests have mentioned, the support of residents and fellows. That has happened on a few of my trips, and that is ingenuous because it truly does allow for the educational aspect to occur. Oftentimes it'll ignite a humanitarian spirit into that individual, which will propel them to do more and more. Not everybody, but quite a few. So any sort of financial support is obvious, as Dr. Aziz has said as well. The other thing that I think is important is IOMS is it's a very powerful organization. It's a great organization, and it can bring awareness just the fact of bringing awareness through its website, through other avenues of social media, which is so strong now, just bringing awareness of the problem that we have amongst some of the residents, some of the fellows, some of the new practicing surgeons. That's all good stuff. Now, obviously, the database. I agree 100% that the collection of all these good groups doing so much good work, if we all knew a little more about each other and we were all able to help each other in some way, I guess we would have no idea what may come to fruition through that. I think that is very, very important. And then finally, one thing that wasn't mentioned that I think is important for IOMS is I believe that we need to create a global standard of care. I think one thing that is very important for us to do is to create a global standard of care of what we do overseas. I am coming I only do the cleft surgery overseas, so I don't do NOMA and orthognathic surgery overseas currently. So I'm coming from a cleft perspective, but to have that standard of care of what these many great groups are going over there would be wonderful for our organization, such as other specialties that have done this, to come up with this and together and collaboratively form this.
Great. Well, our time is just about up. Thank you very much for sharing your personal experiences and your insight. What a world of great things just in in this small group. So the point of bringing other folks in IOMS together to get to the collective, the aggregate power of that is astonishing to think about. But if we don't know about each other, then that can't be done. Support for education and support for the educational endeavors, capacity building, both capacity for surgical outreach in the high-resourced areas and capacity for the low-resourced areas. The foundation is well on its way to supporting a number of the things that we've talked about. We just need to get some of the membership and others to help with that effort. Getting out on the website, getting out on social media, I think, is a good way to start acquainting people with it, and I think that should be an easy thing without too much investment. So I want to thank all of you and wish all of you a great evening or morning or day. We'll look forward to getting together as soon as it's safe.
Thank you once again for listening to our celebratory podcast series, the IOMS Foundation, 25 Years and Beyond. We are grateful to all of those who volunteered their time to participate in this series and for their continued support of the IOMS Foundation. I would also like to extend my appreciation to our corporate and foundation partners, KLS Martin Group, the Osteoscience Foundation, and the OMS Foundation for their ongoing support. To learn more about the IOMS Foundation's programs and opportunities, or to make a gift to the foundation, visit www.iomsfoundation.org. We look forward to connecting with you soon.